Good morning, all. We will have a discussion about the local anesthesia. I hope everyone knows what is the local anesthesia. So, coming into it, introduction, it is widely used method of pain control, a painless treatment, comfort to the patient. Coming into the historical background. So, cocaine is the first local anesthetic agent which is isolated by Nyaman in 1860 from the leaves of coca tree. Its anesthetic action was demonstrated by the Carl and Kohler in 1884. First effective and widely used synthetic local anesthetic cocaine is produced by Ian Horn in 1905 from benzoic acid and diethyl amino ethanol. I have included this slide because sometimes you might get a question stating that who isolated from where and which local anesthetic agents has been produced by Heinhorn. Some questions are related to this. That's why I put the slide. Its anesthetic property were identified by Beaverfield and the agents was introduced into the clinical practice by the Bond. Lignocaine, which is introduced by the Lofgren in 1948. The discovery of its anesthetic property was followed in 1949 by its clinical use by God. Thereafter, a series of potent anesthetics soon followed with a wide spectrum of clinical properties. Coming into the local anesthesia is defined as loss of sensation in the circumscribed area of the body caused by depression of excitation in the peripheral nerve endings or inhibition of conduction process in the peripheral nerves, which is given by Stanley Malamet in 1980. It means that there will be a loss of sensation without the loss of consciousness. Local anesthetics are the drug which upon topical application or local injection will cause reversible. So state that. So insisting the word is reversible loss of sensory perception, especially of a pain in a localized area of body. There is no structural damage to the neuron takes place. What are all the desirable properties of local anesthesia? It should be non-irritating. It should not cause any permanent alteration of nerve structure. Its systemic toxicity should be very low. Time of onset should be shorter. It should be effective regardless of whether it's injected into tissue or applied locally to mucous membrane. Duration of action should be long enough to permit the completion of the procedure. In addition to these qualities, Bennett lists other desirable properties of ideal local anesthesia. It should have a potency sufficient to give a complete anesthesia. It should be free from producing allergic reactions. It should be stable in a solution and relatively undergo biotransformation in body. It should be either sterile or capable of being sterilized by heat without deterioration. Coming into the pharmacology, the classification includes butadiene, cocaine, benzocaine, hexacaine, and tetracaine, chloroprocaine, procaine, and propoxycaine, atricaine, bupivacaine, dibucaine, etidocaine, lignocaine, mepivacaine, and prilocaine. These are all the classification of local anesthesia based on its groups. It's maybe an ester group or amide groups, and these are all the classification of the local anesthetic agents. So it includes as if they told that it includes there have been a surface anesthetic and injectable form. So the surface anesthetics, which includes cocaine, tetracaine, lidocaine, benzocaine, and oxyethacaine, whereas injectable forms are atricaine, bupivacaine, ropivacaine, deuterocaine, and remaining others are the injectable forms. So remember, this is the classification of local anesthetic agents based on the pharmacological. It is injectable and the surface. Surface is lignocaine, cocaine, tetracaine, benzocaine, propoxycaine. Short and injectable will be procaine, chloroprocaine, lignocaine, prilocaine, tetracaine, bupivacaine, dibucaine, ropivacaine. So I'm repeating it once again so that you people can able to remember it in a nice way. So they are, so if you're not able to correlate it with this, so just remember, and they are all called as surface acting, and injectable local anesthetic agents, surface acting or lidocaine, cocaine, tetracaine, benzocaine, oxyethoxane, propracaine, injectable or procaine, chloroprocaine, lignocaine, prilocaine, tetracaine, bupivacaine, ropivacaine, dibucaine. Coming into the based on the biological site and the mode of action, it has been classified into class A, B, C, and D. Class A are tetrodotoxin, saxitoxin. Class B are quaternary ammonium compounds. And class C are benzocaine. Class D are lignocaine, mepivacaine, and prilocaine. Based on the mode of application, so as I told, it's topical and injectable. So I hope you people have heard that in the previous slide itself. Anyway, I'll repeat it again. Topical are divided into soluble and insoluble. Soluble are cocaine, lidocaine, tetracaine, binoxinate, whereas insoluble are benzocaine, butylaminobenzoate. Whereas injectable are lidocaine, mepivacaine, tetracaine, bupivacaine, and dibucaine. Coming into the based on the duration of an action, they are ultra short, short, medium, and long. Ultra short are pulpal, which is less than 10 minutes, soft tissues 30 to 45 minutes, chloroprocaine and the procaine, which comes under the ultra short acting. Coming into the short acting are pulpal anesthesia will be of 5 to 10 minutes and soft tissue anesthesia will be of 60 to 120 minutes, which includes lidocaine and prilocaine. Coming into the medium action, the duration will be pulpal 45 to 90 minutes, soft tissue 120 to 240 minutes, which includes mepivacaine and atricane. Coming into the long acting, the duration of an action is pulpal 90 to 180 minutes, soft tissue is 240 to 540 minutes, which includes bupivacaine and etidocaine. Coming into the based on potency, low, intermediate, high. Low is procaine, chloroprocaine. Coming into the intermediate, lidocaine, mepivacaine. High, tetracaine, bupivacaine, and dibucaine. I hope you people can correlate with the duration and the potency of actions. Coming into the lidocaine first. So we'll see the lidocaine, and following slide we'll see the theories and the mechanism of action. Lidocaine is also called as xylocaine, lignocaine, common local anesthetic and antiarrhythmic drug. Most widely used local anesthetic agent by all the routes. It's a faster onset, available as injection, topical solution, jelly, and ointment. Lidocaine is used topically to relieve itching, burning, and pain from skin inflammation, injected as dental anesthetic or as a local anesthetic for a minor procedure. It is more intense, long-lasting than a procaine. Sets on quickly and produce a desirable effect for several hours. Good alternates for those allergic to ester type. More potent than the procaine but about equal toxicity. It relieves pain during a dental surgeries, quicker CNS effect, antiarrhythmic, cause little allergenic reaction, and it's hypoallergenic. With vasoconstrictor, so the duration is 5 to 10 minutes and the tissue for pulpal is 5 to 10 minutes and the tissue is 1 to 2 hours. If you are going to use a vasoconstrictor in the dosage of 1:1 lakh ratio, pulpal anesthesia will be 60 minutes and tissue will be 3 to 5 hours. Time to onset is 2 to 3 minutes. Half-life will be 90 minutes. What is the maximum recommended dose? You will get a question in this. The maximum recommended dose is 4.4 milligram per kg, 2 milligram per lb. Without epinephrine is 4.4 milligram per kg. With epinephrine is 6.6 milligram per kg. The maximum safer dose is 2% with 1:1 lakh epinephrine. According to the Malamat, it's 300 milligram or 8 carpules or manufacturer. According to the manufacturer, the 300 is 500 milligram or 13.5 carpules. So this is the calculation. Sometimes you will get a question based on this. What will be the maximum dose based on the melamine? Coming into the use, 2% lignocaine with 1 is to 50,000 epinephrine is used for hemostasis, whereas 2% lignocaine with 1 is to 1 lakh or 1 is to 2 lakh is used as a local anesthetic agent. Comparison of lignocaine with the procaine. Lignocaine is a more rapid onset of action, more profound anesthesia, longer duration of action, and greater potency. Coming into the theories of action of local anesthetic agents. There have been many theories, but the few are only accepted theory, like receptors theory, specific receptor theories are most commonly accepted theory. The other theories includes acetylcholine theory, stated that acetylcholine was involved in the nerve conduction. I hope everyone knows this. In addition to this role as a neurotransmitter, it has at a nerve synapses, it is also used in the conduction process. So there is no evidence to prove that acetylcholine is involved in the nerve transmission. Coming to the calcium displacement theory, it states that local anesthetic nerve block was produced by displacement of calcium from some membrane site that control permeability of sodium. Surface charge or the repulsion theory, at least you know down this, the highlighted words, like green highlighted words, propose that local anesthetic agent are acted by binding to the nerve membrane and changing the electric potential at the membrane surface. Cationic drug molecules were aligned at the membrane water interference. Since some of the local anesthetic molecule are carried a net positive charge, they made the electric potential at the surface more positive, that decreasing the excitability of nerve by increasing the threshold potential. Current evidence indicate that resting potential of nerve membrane is unaltered by local anesthetic agent. Coming into the membrane expansion theory, it states that local anesthetic molecules diffuse to the hydrophobic region of excitable membranes, producing a general disturbance of bulk membrane structure, expanding membrane, and thus preventing an increase in permeability to sodium ions. Lipid soluble LA can easily penetrate the lipid portion of cell membrane, changing the configuration of lipoprotein matrix of nerve membrane. This results in decreased diameter of sodium channel. Once the diameter of sodium channel has been increased, the conduction will be obviously get inhibited and the excitation will be stopped. So this is the picture which shows that membrane expansion theory. How does it works? Coming into the specific receptor, which is the most favorite theory nowadays, propose that local anesthetic is act by binding to the specific receptors on a sodium channel. I hope everyone knows that cells are lipid bilayer. So the local anesthesia, to produce the anesthetic action, it has to cross this lipid bilayer. The action of the drug is direct and not mediated by some changes in the general properties. Biochemical and electrophysiological studies have indicated that specific receptor sites for local anesthetic agents exists in sodium channel either on its external surface or on an internal axonoplasmic surface. So this is the one which shows that there are two groups of local anesthetic agents. I hope everyone knows that they are ester and the amide group of local anesthetic agent. Esters and the amide are the one which will link the local anesthetic have two compounds, like aromatic and aliphatic compounds. See, these are the two compounds of local anesthetic agent. So aromatic and the aliphatic compounds are linked by either ester group of local anesthetic agent or maybe amide group of local anesthetic agents. So based on the binding of local anesthetic agents, so whether it's ester or amide, it has been classified into ester group of local anesthesia and amide group of local anesthesia. I hope everyone has a mnemonic how the ester groups has been classified. I'll tell you. The ester groups are benzocaine. So kindly note down it, because sometimes you'll get a question. Please note down and take a paper and note down it. I'll repeat it. Ester and the amide groups and the other groups. Esters are benzocaine, cocaine, chloroprocaine, exalkyne, piprocaine, procaine, tetracaine. So I am repeating it once again. It's benzocaine, cocaine, chloroprocaine, tetracaine, and then proparacaine. If it is not easy for you to remember, just remember benzocaine, cocaine, chloroprocaine, and tetracaine are ester groups. So coming into the amide groups are atricane, bupivacaine, lignocaine, etidocaine, mepivacaine, prilocaine, ropivacaine. So I'm repeating it. Amide groups are the group which determines whether the two bonding of local anesthetic has to be done in amide. Amide groups are atricane, bupivacaine, dibucaine, etidocaine, lignocaine, mepivacaine, prilocaine, and the ropivacaine. Others are diclonine and then paramoxin. I'm repeating it. Others are diclonine, diclonine, and pramoxine, pramoxine. So they are other groups of local anesthetic agent. So I hope still now you people are clear about the what is this local anesthetic and classification of local anesthetic agent. Coming into the mechanism of action of local anesthetic agent. So first we'll see what is the mechanism of action of local anesthetic agent. How does the local anesthetic agent acts? It's a very simple mechanism. So everyone, I hope everyone knows this is a mechanism. Just follow this picture and hear my class. Local anesthetics blocks the voltage gated sodium channel, so that it blocks the voltage gated sodium channel. So once the voltage gated sodium channel has been blocked, there will not be any entry of sodium ion into the cell, so that the depolarization will not be there. So in initial state, the membrane potential will be minus 50 to minus 60 MV. So once there is no depolarization, the generation of action potential will not be there. So there is no generation of action potential, followed by no generation and conduction of impulse to the central nervous system. As a result, the local anesthetic agents, the function has been achieved. I'm repeating it once again. So the first step will be the blockade. Local anesthetic agent will block the sodium channel, and once it has been blocked, there will not be any entry of sodium into the cell. So no depolarization, no generation of action potential, no conduction of impulse to CNS. Local anesthesia will get achieved. So remember, so displacement of calcium ion from sodium receptor channel, binding of local anesthetic to the receptor, blockade of sodium channel, decrease in the sodium conductance, depression of rate of electric depolarization, failure to achieve the threshold potential, lack of development of action potential, and finally conduction blockade. So coming into the most important point, sometimes you will get a question in pharmacokinetic and pharmacodynamics also. That's why I've added this. And the composition, that's the most important part of the local anesthetic agent. So you should know the composition. Composition, it includes local anesthetic agent, either a xylocaine or lignocaine, which is the one which is a main hero for the nerve conduction blockade. Vasoconstrictor, it is the one which is used to prolong the duration of an action and increase the depth, decrease the absorptions of the local anesthetic agent. Sodium metabisulfate are reducing agents for antioxidant for a vasoconstrictor. So remember, sodium metabisulfate are the reducing agent for the vasoconstrictor. Methylparaben, and then which is a bacteriostatic agent. Thymol is a fungicide. Vehicle is distilled water and sodium chloride. It's a volume and isotonicity for solution. Chemical characteristics are so balanced that they have lipophilic and the hydrophilic properties. If hydrophilic groups predominant, the ability to diffuse into the lipid-rich nerves is diminished. If the molecule is too lipophilic, it is of little clinical value as an injectable anesthetics, since it is insoluble in water and unable to diffuse through interstitial tissues. Coming into the pharmacokinetics, uptake is oral route, topical route, and injection. Either amide or ester groups of local anesthetic agent. If it is amide, excretion will occur through kidney. Ester is excretion occurs through the blood vessels using a pseudocholine esterase. And coming into the pharmacodynamics, because like sometimes you'll get a questions based on the pharmacodynamics also. So the pharmacodynamics, the first action will get lost will be a pain, followed by temperature, followed by touch, followed by proprioception, followed by skeletal muscle tone. So I hope you people will remember. I don't want to repeat it again. The first functions is pain perception, temperature, touch, proprioception, skeletal muscle tone will get lost. The action will be, the reversal will be in the opposite side. First, skeletal muscle tone will get reversed first, proprioception, touch sensation, temperature, and the pain at last. And sensory nerves, so note down as sensory nerves are more commonly affected than the motor nerves. Coming into it, the sensory nerves, as I told, it's more commonly affected than the motor nerve. Non-myelinated are more commonly affected than myelinated. Small fibers are most commonly affected than large fibers. Autonomic nerve fibers are most commonly affected than the somatic fibers. Coming back into the vasoconstrictor, I had a few slides for the vasoconstrictor. Decrease blood flow, low anesthetic blood volume, decrease the risk of toxicity, and increase duration of action, decrease bleeding. Vasoconstrictors are classified into catecholamine and non-catecholamines. Catecholamines are epinephrine, norepinephrine, dopamine, levonorepinephrine, isoproterenol. Non-catecholamines includes amphetamine, methamphetamine, hydroxyamphetamine, ephedrine, and mepetermine. Epinephrine are maximum dose for dental appointment. Normal healthy patients 0.2 mg per appointment. Significant cardiovascular impairment 0.04 mg per appointment. So this is the most important question. Maximum dose for dental appointment. If it is a healthy patient, the adrenaline up to 0.2 mg can be given. Whereas in case of patient present with the cardiovascular impairment, 0.04 mg should be given. Norepinephrine maximum dose for healthy patient is 0.34 mg per appointment or 10 ml of 1:30,000 solution. Patient with the cardiovascular disease 0.14 mg per appointment or 4 ml of 1:30,000 solution. So what is the factors in selection of LA for a patient? Length of the time the pain control is necessary. Potential need for post-treatment pain control, possibility of self-mutation in the post-operative period, requirement for hemostasis, presence of any contraindications of LA solution selected for administration. So common questions might ask you, these are all the common questions. Sometimes they will ask you what is the recommended dose and what are the classifications of local anesthetic agents, and the mostly they'll ask you questions like a recommended dose and classifications of the local anesthetic agent. So remember that recommended dose and classification, so that, and followed by the what are the routes of local anesthetic agent, how we are going to administer the local anesthetic agent, what are the composition of local anesthetic agent, and who gave the definitions, and which local anesthetic agent has been introduced by which author, and sometimes a year, and which is the antioxidant, and what are the techniques available. Some important techniques, accessory techniques you will get, local complication, what are all, and sometimes they will have an odd and rule out these, which are all the local complications, rule out the general complication or systemic complications. So the questions will be like this. So when you're going to prepare for local anesthesia, take a book, just write down the definition, classification, and the few authors history which I have given in the slide. Pharmacokinetics, pharmacodynamics, I have told you, and I hope you people have read that. Pharmacodynamics, pharmacokinetics, I am not going in detail because these are all the pharmacological topic. That's why I didn't put some slides over that. Pharmacodynamics, pharmacokinetics, followed by the composition, and followed by classification, what are all the theories, most commonly accepted theories, and followed by mechanism of an action, and followed by recommended dose, and LA with adrenaline, without adrenaline, only adrenaline for healthy and cardiac patient, followed by maxillary nerve block technique, mandibular nerve block technique. For that, one should know the anatomy of maxillary nerve, mandibular nerve. Followed by what are all the maxillary nerve block technique and other names for maxillary nerve block technique, what are the accessory nerve block techniques, intraoral techniques, extraoral techniques. Similar thing for mandibular nerve block, what are all available for mandibular nerve block technique, what are all the other names for mandibular nerve block technique, extraoral techniques, accessory techniques. Followed by what is the local infiltration, followed by what is the complications, systemic complications, and the local complications. So this is the way you have to prepare for your MCQs, so that it will be easy for you, so you can able to remember this till your end of the exam, not only the end of the exam, till your end. So from this I'm completing the class starting with LA introduction. In upcoming class we will see the remaining other topics. I hope you people have understand the class very well. If you have any doubt or if you want to know anything in detail, just please let me know. Thank you.